So hello dosto, and now we are going to discuss about the VKC or spring catarrh. So the definition. So it is allergic inflammation of the conjunctiva which is recurrent, bilateral, interstitial and self-limiting. Its incidence is periodic and seasonal incidence is there. Then etiopathogenesis. Previously it was considered as type 1 IgE mediated hypersensitivity reaction to the pollen allergens, but now the pathogenesis is characterized by Th2 lymphocyte alteration and X-aggregated Ig response to the common allergens. Now, what are the predisposing factors? First, it is seen in the 4 to 20 years of the age and in the boys mostly. Then in the summer season, in tropic climate, it is associated with eczema and asthma, and in the patient with family history of atopy. Then pathology. In the pathology, there are 4 points. First is the conjunctival epithelium. Here increase in mast cell and eosinophils is there, hyperplasia occurs, and there is a downward projection through the conjunctival epithelium. Then adenoid layer and fibrous layer. In adenoid layer there is increase in cellular infiltration like mast cell, eosinophils, plasma, lymphocytes, and in the fibrous layer there is a proliferation and hyaline changes occurs. Then conjunctival vessel, there will be proliferation, increased permeability and vasodilation. Like here is the vasodilation, increased permeability, and there will be the proliferation. This all results in the multiple papillae in upper tarsal conjunctiva. Now clinical features, symptom and signs. Most important symptoms are burning and itching sensation, which increases in the warm and humid atmosphere, and these are intolerable symptoms. It can be associated with photophobia, stringy discharge, lacrimation and heaviness of the lid. You can remember this image. Now signs of VKC. So first is palpebral VKC, second is bulbar, and third is mixed. In the palpebral VKC, the location is bilateral upper tarsal conjunctiva and the lesion is hard flat stopped papilla with conjunctival hyperemia will be there. The papillae are arranged in the cobblestone and pavement stone appearance. In severe cases, hypertrophy of papilla is seen, which is called as the giant papillae, which is cauliflower-like appearance. And in the palpebral conjunctiva only, when there is a corneal involvement of the VKC, it is known as the vernal keratopathy. Then second is bulbar limbal VKC. In these 3 points are there. First is dusky red triangular congestion, as you can see here. Then limbal papilla has gelatinous limbal membrane, and third is the Horner-Trantas spot, which are white in color at the limbus, and in the mixed there is a combination of both. Now the treatment part. Topical anti-allergic and anti-inflammatory drugs are used. Its dual action is used for, it is a treatment of choice in mild to moderate cases. It controls and prevents the exacerbation. For example, olapatadine and azelastine. Mast cell stabilizers, for example, sodium chromoglycate 2%, 3 to 4 drops per day. Third is topical steroid, which is reserved for moderate to severe cases. It can cause steroid-induced glaucoma and therefore monitor intraocular pressure and taper the dose as required. Its examples are fluorometholone 0.1% and loteprednol 0.5%, prednisolone, beta and dexamethasone. Then fourth is immunomodulator. In severe disease, plus when there is a steroid is not used, in these cases cyclosporine and tacrolimus are used as immunomodulator. Then another is lubricant and mucolytics, in that artificial tear, and for example carboxymethyl cellulose is used and acetylcysteine is used in the early plaque formation. Then systemic therapy, there is oral antihistaminic and steroids. Oral antihistaminic is will reduce the itching, and oral steroids, when there is advanced very severe case, we can use oral steroids. Then treatment of giant papilla. Long-acting steroid injection can be given supratarsal. Then cryo application and surgical excision can be done. Then suppurative measures can be taken. For example, dark goggles are given, cold compressions can be given. Then eye rubbing is not recommended here. Then treatment of VKC. For punctate epithelium keratitis, instillation steroid is increased. Then for large vernal plaque, superior keratectomy is done. And shield ulcer, there is when there is resistance to the medicine, do surgery. Thank you.